The itemized bill arrives and one line stops you cold. Acetaminophen 5 tablet. Quantity 2. Charge 83. Acetaminophen is Tylenol. You can buy a bottle of 100 tablets at Walgreens for $8.49. 2 tablets at Walgreens, 17 cents. 2 tablets at the hospital, 83 hours. You scroll down. IV fluid administration. Normal saline, 1L, $200. Non-skid patient socks, $340. You keep scrolling. The bill is 47 lines long. Rachel is an accountant. She requested this document specifically because she knew how to read it. Most people never request it at all, and the system is counting on that. You assumed a hospital bill reflects what your care actually cost, that the prices are tied to something. The cost of the drug, the cost of the equipment, the cost of the staff who administered it. They are not tied to those things in any meaningful way. According to a landmark study published in Health Affairs, U.S. hospitals mark up their actual costs by an average of 4.32 times. 4.32. That means a service that costs the hospital $100 to deliver is billed at 432s. For individual line items, specific drugs, specific supplies, the markup can exceed 1,000%. The $83 Tylenol didn't come from a pricing error. It came from a pricing system, one that your hospital built for itself. By the end of this video, you will understand exactly what the Chargemaster is, the document that generated every number on your hospital bill. You will understand how the markup system works, what your insurance company's negotiated discount actually means, and why it often doesn't protect you the way you think it does. And you will know the one document to request after any hospital stay that exposes billing errors most patients pay without ever questioning. The document that generated Rachel's $83 Tylenol charge is called the Chargemaster. Every hospital in the United States maintains one. It is a master price list, sometimes thousands of pages long, that assigns a dollar amount to every service, drug, supply, and procedure the hospital provides. The hospital sets these prices, not the government, not an independent regulator, not a market, the hospital. And for most of the history of American hospital billing, those prices were kept almost entirely confidential. You could not look up what a hospital charged for an MRI before you had one. You could not compare prices between 2 hospitals in the same city. You could only find out what you owed after you had already received the care. The Chargemaster price is not the price anyone expects you to pay in full. It is the opening number in a negotiation. Insurance companies have pre-negotiated discounts. They bring the Chargemaster price down by 30%, 50%, sometimes 70%. But here is what most people miss. If you have a high deductible plan, you pay out of pocket up to your deductible based on the negotiated rate. Not the Chargemaster price, but still a number derived from it. A discount off an invented number is still a number someone invented. Rachel's 2-day stay generated $47,000 in Chargemaster charges. Her insurer negotiated that to $18,000. She owed $4,200 after her deductible and co-insurance. She thought the system had worked. Then she read the itemized bill. Here is the number most hospital administrators know and most patients have never heard. The cost-to-charge ratio. It is the relationship between what a hospital actually spends to deliver a service and what they bill for it. A cost-to-charge ratio of 0.23 means the hospital's actual cost is 23 cents for every dollar they charge. According to CMS data analyzed in the Health Affairs study, that 0.23 figure is close to the national average. For every dollar on your bill, roughly 23 cents represents actual cost. The other 77 cents is markup. For the $83 Tylenol, at a 0.23 ratio, the hospital's actual cost was approximately 19 cents. A hospital doesn't charge $80 for a Tylenol because Tylenol costs $80. It charges $80 for a Tylenol because nothing in the law says it can't, and because the number on your bill was never meant to be the number you pay. Think of the Chargemaster like a restaurant that writes its own Yelp reviews, sets its own prices with no menu posted, and presents the bill only after you've already eaten, in a room with no exit. You couldn't comparison shop. You couldn't negotiate in advance. You were unconscious, in pain, or in an ambulance at the moment you were theoretically supposed to be making a market decision. The American healthcare pricing system is built on the assumption that patients are consumers. Patients are almost never in a position to behave like consumers. And the Chargemaster was built inside that gap. So now you understand where the $80 Tylenol comes from. A price list built by one party, marked up by 4x or more, discounted by a negotiation you weren't part of, and presented to you as a bill after the fact. In 2021, the federal government tried to fix this. What actually happened is more complicated and more telling about how the system protects itself. In January 2021, a CMS rule took effect requiring every hospital in the United States to publish its standard charges, including its Chargemaster prices, in a machine-readable format, publicly accessible online. The intent was to let patients compare prices before receiving care. The reality was different. A 2023 analysis by the Patient Rights Advocate found that fewer than 25% of U.S. hospitals were in full compliance with the rule. The hospitals that did publish their data often buried it in spreadsheets with hundreds of thousands of rows, using billing codes that require a medical degree to interpret, in formats that no ordinary patient could practically use. The hospitals that didn't publish faced a fine. The original fine for non-compliance was $300 per day. For a hospital generating $100 million in annual revenue, $300 a day is not a deterrent. It is a business decision. CMS increased the maximum penalty significantly in 2022, up to $5,500 per day for large hospitals. Compliance has improved somewhat since, but the fundamental problem remains. Even when hospitals publish their prices, those prices are the Chargemaster prices, the inflated starting point, not the negotiated rates that insured patients actually pay. Rachel found 6 billing errors in her itemized bill: a charge for a medication she was never given, a second charge for a procedure already billed under a different code, 4 supply charges at quantities that didn't match her medical record. She disputed all 6. The hospital corrected 4 of them. Her bill dropped by $1,800, not because she had a lawyer, not because she had special knowledge, because she read the document and asked a question about every line that didn't make sense. Most patients never see the itemized bill. They pay the summary statement, one total, no explanation, and move on. The system is built around that. Here is what Rachel knows now, and what changes the moment you know it too. First, always request the fully itemized bill, not the summary statement. The itemized bill, sometimes called the detailed statement or the UB04, lists every single charge with the billing code, the quantity, and the unit price. You are entitled to this document. Ask for it in writing from the billing department before you pay anything. Second, cross-reference the quantities. For any supply item, medication, or procedure listed more than once, verify it matches your medical records. Ask your doctor's office for a discharge summary, a document that lists everything done during your stay. Compare it to your itemized bill. Any charge that appears in the bill but not in the discharge summary is worth a formal written dispute. Third, look up the hospital's cost-to-charge ratio. CMS publishes this data publicly for every Medicare-certified hospital in the United States. The link is in the description. It tells you, at a facility level, the relationship between what the hospital charges and what things actually cost. Fourth, if your bill is over $5,000 and the itemized review feels overwhelming, contact a medical billing advocate. Many work on contingency, a percentage of what they save you, no upfront cost. The Patient Advocate Foundation directory is in the description. Rachel saved $1,800 by reading one document. An advocate saves the average patient significantly more. The $80 Tylenol wasn't an error. It was a price, set by one party, in a document they built for themselves. In a market where you were never actually shopping, you were in a hospital bed. And the system designed around that moment, at the Chargemaster, the markup, the summary statement, was not designed to make that easier for you. It was designed to make it invisible. Now you see it. And now you know what to ask for before the summary statement becomes the only document you ever read. Right now, if you have had a hospital stay in the last 12 months and paid a summary statement without requesting the itemized bill, call the billing department today and request it. 12 months is within the window where corrections can still be applied. The CMS Hospital Cost-to-Charge Ratio data and the Patient Advocate Foundation directory are both linked in the description below. If you know someone who is about to pay a hospital bill without reading what's on it, send them this video first. Reading the itemized bill before paying is the single highest return action available to any hospital patient. It takes 30 minutes and costs nothing. Drop in the comments. Have you ever looked at an itemized hospital bill? What was the most surprising charge you found? Tell me. I read everyone, and your examples are the next person's warning. Next week on Body of Debt. And this one is going to be uncomfortable. Most Americans have been told their whole lives that being overweight is a personal failure. What nobody told them is that the food system, the healthcare system, and the insurance system all profit more when you stay sick than when you get better. We're following the money on obesity in America, fear, chronic disease, and a very specific financial trail. Subscribe so you're there.